Hello, I'm Dr. Barry Tedder from St. Bernard's Heart and Vascular in Jonesboro, Arkansas. I've been in interventional cardiologist for 30 years and have been working with the Pantheris device since its inception and in the initial clinical trials. Today, I'm going to go over a couple of case studies. This is a patient, is a 61-year-old white male, has had previous CTO intervention on the right side, and it presented with increasing Rutherford class 3 lifestyle empty claudication with severe SFA popliteal diffuse disease. He had about a 50% left iliac stenosis. We managed his lipids adequately and is working on blood pressure control. And despite exercise program, continue to have lifestyle empty claudication. We'll see on the angiogram, all these are still frame digital shots. So we have diffuse SFA disease. And the image on the left, you can see this tight stenosis at the bottom of the image, or the same stenosis at the top of the image on the right, with kind of diffuse proximal disease of 50 to 70%. So our main objective was to try to debulk it, and this illustrates the importance of having OCT guidance, where we can actually see what kind of plaque it is and cut only the plaque and not the deep structures, and determine, what the pathology is to help our treatment modality choices. This is an angiogram of patient's left SFA, and we see some moderate mid SFA disease of 50 to 70% diffusely throughout the vessel, which we see a lot in the SFA in the high-grade distal. These are the OCT imaging. We can see significant plaque there and cutting of the plaque down to the deep structures. As we rotate over into plaque and try to stay away from the media and the deep structures, we rotate the device into the plaque, get good balloon apposition, and then start cutting. This plaque is going fairly well. Good cutting all the way down to the media. Again, you see the plaque, there's been a little bit of cut already, but we want to kind of compress against it and rotate into the plaque away from the deep structures that we've already cut or where normal vessel is. Again, fairly good debulking through the proximal to mid SFA. Here we see the calcified nodule at 6 o'clock. We see the trough that we've already created from previous cut. And now, again, the calcified nodule, we see it more like 9 o'clock in this view, and we can cut all around it. So sometimes we have those nodules, we can cut parts of it out. And this time it's quite a hard nodule. We try to cut all the plaque near it, around it, and try to cut it, but often it will bounce off those really firm calcified nodules. But what we learned from that is that they might need a different modality to really address calcified, and I chose a scoring balloon, which did help cut that plaque up and be able to expand the balloon for that. We'll see that we're going to go in with the Pantheris XL. I really like the long nose cone because you can get a lot of plaque and use only up to 2, maybe 3 passes instead of having to use multiple passes, and can debulk a whole SFA substantially. We also know that those are very difficult to cut with the Pantheris, but I try to cut like all around it and debulk most of the plaque around it. We ended up going up to the 6 device speed to try to do a little bit more robust cutting, and we're able to cut some of the plaque. But one of the things we learned from this case is that one, you debulk as much as you can all around it, and when you see that they have calcified nodules or something that's too difficult to cut, then you can use a different modality. But I think the thing we learned from this case is that you get better imaging, and then we go in with cutting balloon or scoring balloon, and then I finished it off with a long drug-coated balloon, which is typically what I often do because I can feel like I can get nearly stent-like results with the debulking and then drug-coated balloon without having to stent. Sometimes we'll have an isolated area of dissection to stent, but often we have minimal dissections and very good luminal gain by debulking a long SFA lesion. Still, we work on really focusing on the tightest area and spend a lot of time on that tight area trying to get all the different quadrants while noticing OCT imaging, what we're getting. I try to get as much debulking as possible without making the procedure last forever. So usually I get right with two long passes and significant debulking and long lesions, even CTOs with lung disease. I think the take-home message again is that we get good OCT guided imaging where we can see exactly where we're cutting, and we cut only plaque and try to stay out of the deep structures, therefore reducing the restenosis rate that we saw with other atherectomy devices when you get to deep structures. And I think learning what the type of plaque is, and when you have calcified nodules or different calcified areas, it give you an idea that maybe you need a different modality as well. But to maximally debulk everything else and come back and deal with the calcium a different way. Sometimes the cutting device is robust enough to cut a lot of calcified plaque, but not always the nodules and things like that. But it does help guide your therapy. We have excellent results with drug-eluting balloon without a stent.